Good afternoon, everyone. My name is Dr. Kishore Baske, practicing pediatric endocrinologist and diabetologist from KIMS, Cuddles, Kondapur, and Secunderabad. So, good evening, everybody. So today before going to my talk and presentation, I would like to thank Cuddles Neonatology department and IT department. So, who is making this presentation to happen today? So, thank you. So today I'm going to talk on neonatal thyroid diseases. Mostly I'll cover hypothyroid because of the time constraints. If time permits, I may talk on hyperthyroid or Graves' disease in neonates, but predominantly my talk will be on hypothyroid in children. So next 40 minutes, I'm going to talk on newborn thyroid screening, physiology of thyroid in neonates, what are the clinical manifestation of primary congenital hypothyroidism, what is the diagnostic approach, individual causes, and their management. So as shown in the picture, everybody knows as a spotter, what is the diagnosis? Yes, you are right. This baby most likely having congenital hypothyroidism. Congratulations for the right guess, but it's too late because as shown, like the picture is like a baby of 6 months age. So who is having frank features of congenital hypothyroidism. So newborn thyroid screening is such an important thing. That's the reason I want to talk about predominantly on newborn thyroid screening. So today, my learning objects, especially pertaining to newborn thyroid screening, are what is the importance of newborn thyroid screening? What are the practical aspects of the thyroid screening? Which sample to be sent? At what time should be done? And what test to be performed? How to interpret both screening and confirmatory thyroid test? How to evaluate, manage, and follow up of children with congenital hypothyroidism. Congenital hypothyroidism is one of the most common preventable intellectual disability. 5% of the babies will be symptomatic at birth and only 10% will be symptomatic at first month of life. So 90 to 95% of the babies may not manifest symptoms in first month of life. There will be near normal outcomes can be seen in congenital hypothyroidism if diagnosed and treated before 2 weeks of age. Whereas delay in treatment causes permanent neurological damage. There is an inverse relationship between age at diagnosis and IQ outcome. So as everybody knows, congenital hypothyroidism is one of the most common cause of irreversible mental retardation. So as shown in the picture, as age progresses, the IQ decline. So roughly for every month, there will be 3 to 5 IQ coefficient number will fall down. If we diagnose in first 1 month of life, IQ may be maintained. If you diagnose and started treatment after 6 months, the average expected IQ of a child will be, mean IQ will be 54 only. The more the delay, more the chances of and more the degree of delay in mental retardation. So I have taken predominantly whatever the concerns from the ISPE published papers, ISPE website. So now I'm going to talk on rationale for the newborn screening. Congenital hypothyroidism is one of the common problem. 1 in 1000 to 1500 babies will get congenital hypothyroidism, whereas the incidence of classical CAH and galactosemia is comparatively rare. Maybe like 1 in 15,000 to 1 in 60,000 respectively for CAH and galactosemia. And TSH as a screening method is very cheap and easily available, highly effective and relatively inexpensive treatment. So benefit of treating is at least 10 times more than the cost of screening. So that is the reason congenital hypothyroid screening is a birthright for every baby. So what is the thyroid pathophysiology? First trimester, maternal T4 is more important. Iodine concentration will start increasing and reaches maximum level by 10 weeks of gestational age. T4, T3, TSH secretion starts secreting around 12 weeks of gestation. During this period, there will be significant neurogenesis, neuronal migration and proliferation, which is critical for the brain development. Whereas after second trimester, hypothalamic pituitary maturation start to mature. where during this period there will be dendritic expansion, axonal growth, myelination, and glial cell proliferation. So by 34 to 36 weeks of age, neuronal migration will be completed, mostly in cortex and hippocampus. Cochlear and cerebellum also maturation completed by 30 weeks. So fully achieved thyroid hormone synthesis is also completed by 30 weeks, 36 weeks of life. So first trimester, it is a maternal T4 dependent predominantly, whereas a second and third trimester partially dependent maternal, but significantly there is a fetal T4 dependence. So lack of which will cause irreversible mental retardation in children. So as shown in this picture, all hormones, all substances, nutrients, medicines from mother will be transferred to the babies except TSH. So even TRH, T4, T3, iodine, radioiodine, trap antibodies, antithyroid drugs, beta blocking drugs, all will be transferable through placenta from mother to the baby, whereas the only TSH hormone which will not be transmitted from mother to the baby. So post birth, TSH surge will be there after birth. It start rising after 30 minutes of life, and there will be normalization by 3 to 5 days, and the peak TSH surge will be at 24 hours of life. And after 3-5 days, why there is a normalization? Because of the cold extrauterine environment. So the initial surge will be for the TSH, whereas subsequent surge will be there for T4 peak. It starts by 24 hours of time, and it may take few weeks to maybe a 1 or 2 months of life also. Diminished TSH and T4 surge in preterm neonates will be there. So the T4 surge will be less and it will be prolonged in preterm, whereas in term TSH surge will be very rapid and the amount of TSH surge will be very high and the normalization may take less time. So as shown in this picture, preterm babies, TSH surge will be less and the time to become normal will take more when compared to term babies. So by doing cord blood sample, T4 surge will not be affected because within 30 minutes we are going to cut the cord and then we are going to collect the sample. Whereas postnatal samples collected before 48 hours can have a high false positive rates. So which sample to be taken? Whether it should be cord blood, whether heel prick blood or venous sample I'm going to present. Like whereas in cord blood, what are the advantages of cord blood is there is a spared TSH surge, useful in early hospital discharges. There is no specific reagent is required or equipment, no prick for newborn babies. What is the caution? Blood collection should be from the placental end of the cord. It should be from the umbilical vein. What is the disadvantage? Requirement of around the clock personnel because delivery may happen in the midnight also. So the expert should be available even during the midnight during emergency situation. Whereas a postnatal sample, especially heel break, what is the advantage? Is the screening of other conditions like galactosemia, phenylketonuria, CAH. So which are predominantly depends on feeding the baby. So before establishing full feeds, those screening tests should not be advisable. So we can combine with galactosemia, phenylketonuria, TSH screening, and even we can do it for the home delivery babies. What is the disadvantage? Neonatal TSH search may cause false positivity. It requires special reagents and equipment. Requirement of trained personnel is there. What is the caution? Error-free blood spots. So as shown in the picture, they should completely fill the circle. Half circle or unfilled circles may give wrong results in babies. How to collect the samples? So it should be from the placental side of the cord. Wipe the maternal blood. It should not be contaminated, and we should collect at least 3 to 5 ml of blood, cutting between the clamp and placenta. And we have to store at 4 degrees centigrade of appropriate labeling. We should transfer to the lab, and we should advise for the lab people to be processed within a day. Whereas a heel prick, lateral side of the lower border towards the heel side area, and it should be air dried and transported at room temperature. It should have a full circle. So half circle or spotted circle is not advisable. When to test? Cord blood should be taken immediately after delivery, whereas a postnatal heel prick should be at least after 48 to 72 hours, but not later than 5 days of time. So cord blood, postnatal heel prick, and even postnatal peripheral venous sample is also advisable. But postnatal peripheral venous sample is acceptable alternative because no special requirement is needed. And venous sample maybe work as both screening and confirmatory test. So when there is no availability, yes, we can go for postnatal peripheral venous sample. If there is accessible and resourceable, all babies should advisable to go for cord blood or postnatal heel prick, whatever is available at the delivering institute. So coming to the term babies and preterm babies, is it different in preterm babies? Should we test like term babies, or should we is it like a different method? Preterm and SJ babies also, the time of testing will be the same. That is 48 to 72 hours after birth if it is a heel prick dry blood sample. For the sick born, newborn babies, at least once they stabilized before 7 days of life, or at least at the time of discharge, whichever is earlier. In special occasions, like as you know, like majority of the newborns, because of the journeys or because of the multiple reasons, they may undergo exchange transfusions, infusions, and because of the critical period and those kind of time. So different cutoff value will be there for the recall, and at least 2 to 4 weeks of exchange transfusion is advisable for the recall or repeating newborn screening. Say for example, heel prick, dry blood spot or filter paper, venous sample, we should advise for the TSH and free T4. So whenever after day 5, why we are not advising heel prick is because of the standardization. And rather than if we advise to do screening test, we have to reconfirm with confirmatory test. As the baby is already 10 days, by doing single venous sample is sufficient, and it will act as a both screening and confirmatory test. So that is the reason whenever you want to screen a baby after 5 days or at least after 1 week of life, it's better to go for venous sample rather than going for heel prick test. So no infant should be sent home without doing any newborn screening test. So which test? So it should be, is it like a TSH based or T4 based? If you prefer TS based, it is more sensitive and more specific, and it is one of the preferred screening test. But the main disadvantage is it may miss central hypothyroidism, whereas T4 based approach, it will help to identify primary and central hypothyroidism, but high false positivity rate will be there and may miss subclinical, or we may miss compensated hypothyroidism. So nowadays in developing countries, we are following TSH based approach. If like a resourceful setting, TSH followed by free T4 method is acceptable method for the newborn screening. So next we are moving into the how to interpret both screening and confirmatory samples. So whenever we advise heel prick on day 3 or cord blood, any serum TSH more than 20, we should we consider it as a screen positive and we have to recall the baby. So if the heel prick are done in between 24 to 48 hours of time, serum TSH more than 34 or equal should be considered as a screen positive, and we should ask them to recall for the follow-up. So in India, we are following ISPE guidelines. Whenever a baby blood test suggestive of TSH more than 20, we consider TSH newborn screen positive. And if the accurate value of TSH is more than 80, immediate sample should be sent for confirmatory test and start on pyroxine supplementation without waiting for the confirmatory test. If the screening TSH level is 40 to 80, immediate confirmatory test should be sent. And if the screening TSH level is between 20 to 40, confirmatory venous test. So whenever the TSH is more than 20, we should send for the reconfirmatory test. More than 80, we have to start immediately treatment. 40 to 80, immediate confirmatory test is required. If it is equivocal, we may wait for some time and then we will recall for the reconfirmatory test. If the confirmatory venous sample at 710 if the TSH screening value is between 20 to 40, we can wait some time and we can ask them to come after 7 to 10 days with confirmatory venous blood test. So either TSH more than 20 in less than 2 weeks of life, or TSH more than 10 after 2 weeks of life should be considered. It is a confirmed hypothyroid case. If there is a associated either total T4 or free T4 is low, we call it as a overt hypothyroidism. If T4 and free T4 are normal, we consider it as a subclinical hypothyroidism. But the TSH is more than 10 in more than 2 weeks or more than 20 in less than 2 weeks, irrespective of the total T4 and free T4 level, the chances of becoming overt hypothyroidism is more. That is a reason even for subclinical hypothyroidism after 2 weeks of life, we should treat them. If it is less than the cutoff value, if at-risk babies, we may call for the recall. If the baby is asymptomatic, not at risk, there is no family history, we can consider it baby is not having any hypothyroid. So the thing is, there is a standardization problem. Whatever the standardization from the lab we will have is TSH for the serum units, whereas TSH in whole blood is completely different. So TSH from the filter paper, usually where we advise to do heel prick test. So either it will be reported in whole blood units or serum units. So before analyzing the report, we should have a idea like are we interpreting either whole blood units or serum units. If it is reported in whole blood units, we have to convert into serum units. For example, if a TSH in whole blood unit has been reported to be 10, but equivalent TSH in serum units will be 22. As the cutoff is more than 20, we have to ask them to follow up. So heel prick or call blood. So just I'm briefing it out because it is one of the most important. At any point of time, TSH is more than 20. If it is serum units or the test is done in between 1 to 2 days of life, TSH is more than 40. After physical examination, confirm with a venous sample. If it is 20 to 40, repeat screening in second week of life. If repeat screening is not possible, so lack of compliance, treat the baby rather than wait and watch. So all TSH values should be serum units. So in TSH followed by T4 approach, if TSH and T4 like TSH is elevated, T4 is low, we call it as a overt hypothyroidism. If TSH is normal, T4 is also normal, definitely is a normal case. If TSH is high, T4 is normal, we call it as a borderline high TSH. We can call it as a subclinical hypothyroidism. If TSH is normal and T4 is low, it could be a case of hypothyroxemia because of prematurity, maybe because of sick thyroid syndrome, maybe because of the delayed rise of TSH, thyroid binding globulin deficiency, maybe a central hypothyroidism. So in overt hypothyroidism, treatment should be initiated as soon as possible, like at least before 2 weeks of life. Next, in future slides, I'm going to talk about like when there is isolated hypothyroxemia or subclinical hypothyroidism, how we are going to deal in subsequent slides. So when there is a borderline TSH with normal T4, as earlier discussed, it could be secondary to prematurity, sickness, it could be sick hypothyroidism, or it could be a thyroid hormone resistance. So we have to repeat after 2 weeks of life. If still after 3 or 4 weeks of life, TSH is more than 10, even T4 is normal, it's better to treat. If isolated T4 is low with normal TSH, we call it as a hypothyroxemia, maybe because of the prematurity or thyroid binding globulin deficiency. So if there is a features of consistent central hypothyroidism, treat it. If there are no features consistent with central hypothyroidism, repeat T4 and TSH after 2 to 4 weeks of life. If still persistently T4 is low, we consider it as a delayed rise of TSH. And after repeating, if still T4 is low, we have to consider it as a central hypothyroidism and need to treat it. And in those dilemma cases like borderline TSH elevated, isolated T4, so rather than treating at general pediatric level, it is better to treat for the expert opinion like pediatric endocrinologist. So take home message is even for the borderline TSH, if the TSH is between 6 to 20, reassure and discharge, follow up is required. So we should not miss them. So when to recheck? When the child is preterm, IUGR baby, sick neonate, having multiple gestation, Down syndrome, first sample taken after transfusion, we have to repeat at 2 weeks of age. And if still that is normal, we can discharge safely. If it is a like borderline elevated, or there is a frank evidence of primary congenital hypothyroidism or central hypothyroidism, need further evaluation and treatment. So coming to the mother is hypothyroid. So what is the difference? If mother is asymptomatic, if the baby is hypothyroid, it is very clear cut. But there is a ambiguity and controversy exists when mother is having hypothyroid. So as earlier I have explained, all hormones will be transferred from mother to the baby except TSH hormone. So if the baby's TSH is elevated, mother having hypothyroid positivity, so it could be transient hypothyroidism, but it will be confirmed by presence of antibodies in mother. If mother antibodies are negative and baby having developmental defects like thyroid dysgenesis or hypoplasia or ectopic thyroid, the possibility of permanent hypothyroidism will be more. So initial normal TSH despite it having hypothyroidism, it could be suppression of hypoparathyroid axis because mother was treated with maternal thyroxine supplementation. So that may cause normal TSH. It could be a false negative screening test. So in sometimes what happened, mother having hypothyroidism, but it was poorly controlled maternal hypothyroidism. So because of that, baby thyroid may be normal, but falsely elevated TSH may be there. So we call it as a false positive newborn. So the take home message is if mother is hypothyroid, the baby may have low normal TSH or high elevated TSH. So in these conditions also, it is better to rescreening the baby after follow-up, irrespective of the TSH level, except if there is any evidence of overt hypothyroidism, treat it. If it is a borderline cases, then in these cases also, you have to call the baby for re-evaluation. And if mother having Graves' disease and having any transplacental antibodies, so child may have a neonatal Graves because TSH stimulatory antibodies are transferred from the mother to the babies. And so in these conditions, child may be symptomatic, but biochemically may have a normal level. So we call it as a true negative. And sometimes what happened, mother having hyperthyroidism, we have started on maternal antithyroid drugs. So these antithyroid drugs will be transferred from mother to the baby, may cause hypothyroidism. So this child may present like a true positive cases. So all these cases we have to analyze, evaluate, and treat with a pinch of salt meticulously. So no baby with having frank hypo or hyperthyroid should not be missed. So that's the reason whenever there is a doubt or borderline cases, please refer to concerned expert. So how to evaluate congenital hypothyroidism? Good history and physical examination. So consanguinity, maternal autoimmune thyroid disease, iodine exposure, preterm and having birth weight, neonatal event should be considered. Child may have on physical examination dysmorphism like midline defects. The chances of central hypothyroidism will be more like cleft palate, congenital heart disease, and hypotonia. And we have to do imaging like ultrasound thyroid and radionuclide scan of the thyroid. It will help in counseling the family to avoid a treatment interruption if there is a suspicion of permanent congenital hypothyroidism. So all suspected or confirmed cases of congenital hypothyroidism should be evaluated for hearing assessment because as 30 to 40% of the congenital hypothyroid cases, there will be association of hearing impairment. So, but for doing evaluation, we should not delay thyroxine therapy for the sake of just doing imaging and hearing assessment. So coming to the etiology, this congenital hypothyroidism may be permanent or transient. So if it is a primary thyroid, it could be thyroid dysgenesis, which constitute almost 80 to 90%. We call it as a athyrosis or hypoplastic, and another could be a secondary to ectopic thyroid. Second most common cause is dysharmonogenesis. It may be because of the sodium iodide importer defect, thyroid peroxidase defect, thyroglobulin defect, or deiodinase defect. And another variant, it could be transient hypothyroidism, maybe because of the maternal thyroid stimulating receptor or blocking antibodies, maternal anti-thyroid drugs, iodine deficiency or excess may prone the baby to have a transient hypothyroidism. Other causes which are rare, like large hemangioma, may present like a consumptive hypothyroidism, secondary to thyroid hormone resistance, secondary to DOUX2 gene mutation or MCT8 mutation may also constitute the causes of congenital hypothyroidism. So even though primary thyroidal problem are more common, still secondary or central hypothyroidism do exist in babies, and it is also one of the common cause of presentation. But the thing is, isolated TSH deficiency is very rare. So usually central hypothyroidism will manifest like a composite multiple pituitary hormone deficiency. So what are the clinical manifestations? Their babies may have a prolonged jaundice, feeding difficulty, lethargy, umbilical hernia, macroglossia, constipation, hypothermia, and sometimes there will be no symptoms at all. And sometimes babies may presented with rare features like excessive abnormal cry, maybe because of the underlying pseudotumor cerebri, or may baby have edema, hypothyroid appearance, or hypotonia. So even baby may not having any other features. If there is an unexplainable cry, hypotonia, we have to screen for congenital hypothyroidism. So there are the one of the most common signs are they have a low birth weight, wide posterior fontanella of greater than 5 mm, open sutures, goiter may or may not be present, may presented with jaundice, puffy face, flat nasal bridge, protuberant abdomen with large umbilical hernia, hypotonia with delayed reflexes, cold mottled skin, absent femoral epiphysis seen in 54 cases. Whereas in Western condition, the reported absent femoral epiphysis may be 20 to 30%, whereas in India, as delayed presentation and missed cases may present with absent femoral epiphysis around 40 to 50% of the cases. So there is a scoring system. We call it as a cubic scoring system. The predominant features may be from head to toe, like large posterior fontanella, umbilical hernia, dry skin, enlarged tongue, nothing but macroglossia, constipation, hypoactivity, void basal niche, icterus, and blood having biochemical evidence of hypothyroidism, which is in subclinical range. So composite value should be like more than like 15, and at least the value more than 6 consider as a suspicion for congenital hypothyroidism. If any clinical criteria crossing more than 6 need a screening evaluation. So like before going to the clinical cases, as shown in this picture, baby having coarse faces, depressed nasal bridge, frontal bossing. There is a relative excess hair, and there is having macroglossia, expressionless, perched mouth, coarse faces. This baby is having. So on imaging, there is no thyroid gland visible in nuclear scanning, suggestive of congenital hypothyroidism secondary to thyroid dysgenesis. And another baby is asymptomatic, 5 years child, just behind the neck, there is a swelling. A nuclear scanning suggestive of ectopic gland, which is a sublingual, and repeating thyroid test suggestive of TSH is elevated, free T4 is elevated, low, suggestive of hypothyroidism in baby. So these are the another cases. 18-month baby, undiagnosed congenital hypothyroidism. Another baby presented with isolated short stature, coarse faces, may presented with pseudo like calf muscle hypertrophy. And another baby asymptomatic, everything is normal, but having only developmental issues, diagnosed by newborn screening, last to follow up, but during follow up, child was presented with hyperactivity and autistic behavior problems. So next, after clinical features, physical examination, I want to move for the imaging, discuss about the imaging, why we need to do and at what time, when we need to do thyroid imaging. I'm going to talk. Why we need to do thyroid imaging is it helps for identifying the cause, helps in counseling the family, can avoid interrupting therapy, because majority of the parents are like on treatment. Whenever they see normal thyroid level, they consider it as a normal, they themselves will stop. So by doing thyroid imaging, we can avoid interrupting therapy at least till 3 years of age. If it is a if permanent, even after 3 years also, if permanent etiology is confirmed. So what imaging we should do? Thyroid ultrasound, thyroid nuclear scanning. So if it is resourceless conditions, any of test can be done. Possible to do thyroid nuclear scanning. If it is not available, yes, can go ahead with thyroid ultrasound. If possible, do both ultrasound and nuclear scanning. When to do? USG can be done even before and after treatment, whereas a nuclear scanning should be done before treatment, at least start off within 7 days of starting treatment. So treatment should not be delayed again for getting the imaging. So after doing, like, when we advise the baby, like after doing thyroid scanning, if uptake is there, but at the base of the tongue, it could be lingual or ectopic thyroid. If there is no uptake in the neck or elsewhere in the body, it indicates that thyroid gland is non-functional, and we have to do thyroid ultrasonography. If it is gland is not visualized, it could be secondary to thyroid agenesis. Gland is seen, but thyroid scan is negative. It could be because of the iodine uptake defect, maybe because of the maternal antibodies or maternal thyroid. So it could be dysharmonogenesis. Increased uptake, USG showing enlarged thyroid, it could be dysharmonogenesis. So ideally we supposed to like go for perchlorate discharge test or genetic test for confirmation. But nowadays in India, we are not doing any perchlorate test, and even genetic tests are we are not routinely advising unless otherwise there is a associated hormonal deficiency, or along with the thyroid problem having associated hearing defects to suspect Pendred syndrome, or associated midline defects like cleft lip, cleft palate, or any heart defects, or any associated pulmonary hypoplasia. In those conditions only we will routinely advise genetic studies, but routinely even for dysharmonogenesis we are not advising further etiological evaluation. Thyroid scan is normal, gland is normal. It could be transient hypothyroidism or maybe dysharmonogenesis also. So earlier I have explained, it is a just replica of the previous slide. So technetium scintigraphy, there is no uptake. It could be because of the dysgenesis, ectopic thyroid gland, or dysplasia. Scintigraphy uptake is there. It could be secondary to dysharmonogenesis. We have to confirm with ultrasonography. So these are the different cases. In first case, scan showing normal uptake in thyroid region. It is a utopic gland. In second case, no uptake. It may be because of the agenesis or blocking antibodies. Whereas in third case, uptake is at the base of the tongue, suggestive of ectopic gland. In fourth condition, fourth case, there is a enlarged increased uptake, goiter, and it suggestive of dysharmonogenesis. So these are the various like nuclear scannings, like how it will be seen. So to have a basic understanding, I depicted the pictures here. So these are the different cases. I don't want to go in detail. So just for having like learning purpose. So other imaging, it is not compulsion. If child is affordable and resourceful condition, and if you feel hypothyroidism is there at birth or before birth to the mother also, so we can advise to do x-rays of the knees and x-ray of the shoulder. Normally epiphyseal region will be there, the femoral epiphysis will be there. Absence of distal femoral epiphysis may help us to tell about the untreated congenital hypothyroidism, and may helps us mother is also not treated completely or something like a partially treated. That kind of background history will also be known, but by doing this, management and evaluation of the condition of the baby may not be altered. So it is not compulsion, but by doing this may help to know whether this onset of congenital hypothyroidism is there at birth or intrauterine time of life. So once congenital hypothyroidism is suspected, screened, evaluated with further testing, and we have confirmed child having congenital hypothyroidism, the only available option for congenital hypothyroidism is replacement. So we have to replace with levothyroxine. The dosage will be 10 to 50 microgram per kg per day. And how to administer? We have to crush the tablet, mix in small quantity of breast milk or water if the baby age is more than 6 months of life. Preferably pre-feed. It ideally in between 2 feeds. It can be given by spoon or palady. Do not add tablet to formula feeds. Avoid iron, calcium, soya, vitamins within 3 to 4 hours of thyroxine supplementation. So we have to counsel the baby that we should not stop thyroxine even during illnesses. So before discharging the baby, after advising treatment, so we have to make sure that we have to give written information to the parents, like whatever I have explained to you, we have to give written explanation, and so that during follow-up also they may go through the document and help them, and they will come to know the importance of continuing the medication. Early and adequate treatment is the key to prevent the neurological damage. So after initiating the treatment, how to further follow up the condition? We have to repeat T4 or free T4 at 2 weeks to know the adequacy of the dose. Whereas after 4 weeks of life, we have to repeat both TSH and T4 or free T4 if resource full condition. If it is in resource limited condition, isolated TSH may be sufficient after 4 weeks of life. And at what time you're supposed to do? Ideally before taking tablet, or at least 4 hours after thyroxine dose. And while doing like supplementation, T4 should be in the upper half of the reference range, whereas TSH should be in the lower half of the normal range. And how often we need to screen it? After starting the treatment, every 2 monthly till 6 months of age, 3 monthly from 6 months to 3 years of age, every 3 to 6 monthly after 3 years of age till end of the growth. After growth, maybe 6 to 12 months. And this is condition is applied when TSH, T4 are in reference range. If TSH is elevated, T4 is in like subtherapeutic range, whenever we are changing the dose, we have to like do follow-up testing after 4 weeks only. So more frequent follow-up may be needed, necessary if frequent fluctuation of T4 and TSH is there. Our aim is we have to keep T4 in upper half, TSH in lower half of the normal reference range. We have to use age appropriate reference range. So just brief, because earlier slide was a very busy for the simplification. So I have like made this like slide. Every follow-up we have to do growth monitoring and developmental assessment. Biochemically, whenever we have started initiate the treatment, we have to do T4 2 weeks, TSH after 4 weeks of treatment. Initial 6 months, 2 monthly follow-up. 6 months to 3 years, 3 monthly follow-up. After 3 years of age, till growth completed, 3 to 6 monthly. After growth completed, we may do follow-up every 6 to 2 monthly. Once dose is changed, every 4 to 6 weekly, we have to ask them with a test report for the follow-up. So whenever we are following up, but we are not able to achieve in therapeutic range of T4 and TSH, what could be the reason? So the reason could be a lack of compliance. So we have to look for the compliance. We need to inquire the technique of administration, because most of the time fasting or in between feeding may be difficult for the parent. So we have to ensure, and we have to ensure that co-administration of other medication should be stopped. So whenever there is a high TSH in presence of high normal or high free T4, so it indicates that there is a chronic poor adherence followed by making up multiple doses before sampling. The thing is, child was not given proper supplementation. So they are aware that TSH will come very high. So to overcome that elevated TSH, sometimes smart parents may give free T4 very frequently to suppress the TSH level. So in that condition, TSH will be very high, simultaneously T4 also will be very high elevated. So it indicates poor adherence and poor compliance of the T4 supplementation. So, and another cause could be pituitary level resistance to T4. If that is the case, then we have to evaluate the baby with genetic testing. So these are the age cutoff values. I'm not going in detail, but just for the easy understanding, when there is a cord blood more than 20, as earlier said, we have to call them for follow-up. And after third day of life, the level more than 20. If it is less than 20, no need to worry at all. Around 4 weeks of life, the T4 and TSH level become adult reference values. So the T4 TSH level may be 2 to 5 after 1 month of life, whereas free T4 level may be 1.23 to 2 nanogram per deciliter. So after 1 month, if any baby having above the adult cutoff values, we can consider baby having like hypothyroidism. So may need further evaluation and follow-up. So what are the indications? We have done newborn screening. Newborn screening suggests of normal TSH and normal T4. But what are the conditions where those babies need rechecking is, so these are the conditions rechecking for permanency of congenital hypothyroidism is like we have to recheck like after completion of 3 years of life, we have to stop thyroxine for 4 weeks, recheck TSH and free T4, and if still TSH is elevated, like more than 10, so we need restarting levothyroxine. If the TSH is 5 to 10, normal free T4, refer pediatric endocrine, depending on the condition, further evaluation will be done. And if still further evaluation suggests of TSH is more than 10 or more than 5, but having risk baby or having frank features of hypothyroid, may need thyroxine supplementation. At any point of time during follow-up, TSH is less than 5, indicate that normal result, we have to consider it as a transient congenital hypothyroidism. We have to safely discharge the baby, but we have to do clinical follow-up. We have to evaluate even if slight suspicion of hypothyroidism during follow-up. So re-evaluation is not required if the baby was proven that having congenital hypothyroidism, like having lingual thyroid or thyroid dysgenesis, or having high TSH while on treatment by 2 years of treatment. So early diagnosis and treatment from the first week of life result in normal linear growth and development, normal scoring in psychometric testing. Whereas a delay in diagnosis, inadequate treatment, and poor compliance result in variable degree of brain damage. Most severely infected babies having lowest T4 levels, retarded skeletal maturation can have a reduced IQs as low, maybe like 50 IQ, and those babies may have other neuropsychological sequelae. So 20%, 30% can have a neurosensory hearing deficit. So that is the reason early diagnosis, early treatment, and adequate follow-up is needed for all congenital hypothyroidism. So now I'm going to discuss what are the practical difficulties, like what are the controversies, like whether those babies to be treated or not. So those kind of things I'm going to talk for the next 5 to 10 minutes of 5 to 10 minutes. So case 1, we have a full-term baby, 2.5 kg, healthy female newborn. Neonatal screen was done by heel prick on day 3 of life. So in newborn screening, TSH is 17. So everybody is aware on day 3 of life, TSH more than 20 need recall re-evaluation. In this case, TSH is having result value of 17. So their reference value is 10. So what is interpretation? Should this infant be recalled for repeat screening or confirmatory sample? So always confirm reporting units. So in this baby, the test was done for heel prick. It is a whole blood unit. It is a dried blood sample. It is not a serum unit. In earlier slide presentation, I have explained to you how to convert whole blood unit into serum units. So you have to multiply the whole blood unit with 2.2, it will give a serum unit. So even though this baby having whole blood unit of 17.17, when you multiply with 2.2, the exact value is coming around 37.5. So the cutoff is more than 20 milli IU per liter. So this baby need recall. So whereas coming to the second case, we have a full-term 3 kg male baby, cord blood TSH more than 300 serum units. So what should be the next course? So there is no doubt at all. So any cord TSH more than 20 or within 24 to 48 hours of TSH level more than 34 or more than 3 days, more than like TSH more than 20, need reconfirmatory test depending on the level. So as heel prick or cord blood TSH is more than 20, earlier I have discussed, and in this case TSH is 100, so more than 40. Physical examination, we need immediate confirmatory venous sample for T for a TSH. As the TSH is more than 80, need immediate start treatment. So the take home message is, as cord TSH is more than 80, immediate confirmatory test, immediately we have to treat the baby without waiting for the confirmatory test. So follow up, as the TSH 20 should be recalled for the confirmatory test. So TSH is more than 40 and TSH is more than 80 venous sample, we have treated the baby. So and confirmatory TSH value came to be 500, free T4 is 0.15. So which are more than 20 and free T4 is less than 1.1 nanogram per deciliter, less than the reference value. Confirm it is a overt primary congenital hypothyroid. So how should this baby evaluated? We should go for etiological evaluation. So this baby underwent X-ray AP view suggestive of absent femoral epiphysis. Hearing screening was done, which was normal, and thyroid scan should be done if possible. So in this case, I could able to do thyroid scanning. There is no visible gland suggestive of thyroid dysgenesis. Further, it was confirmed by ultrasound suggestive of absent thyroid. So it is a frank case of primary congenital hypothyroidism. Etiology is secondary to thyroid dysgenesis. So started on thyroxine 10 to 50 microgram per kg per day. So administration technique explained, written handword was given. Importance of follow-up and compliance was discussed. Asked to follow up after 2 weeks. After 2 weeks, free T4 is in 2.23 with just above the normal. TSH is 28, but dropped from 500 to 28. So should we reduce the dose since T4 is high? Also, what about the high TSH? So labs have a different value. So 500 to 28 is a reasonable value. Within 2 weeks, it has decreased, but it is like, even though it is not less than 20, after 2 weeks of life, the TSH is in the reference range. So as the child is having in reference range, TSH have continued on the same dose, and have the baby was followed up every 2 monthly till 6 months of age. So my aim is, I want to keep T4 in upper half of the range, TSH in lower half of the normal range. So I have followed up subsequently after 6 months, continued on 37.5 microgram per day, and subsequent biochemical thyroid was normal. So baby was higher TSH than is desired. So, but still it is not in the normal range. So we have to check for the compliance, inquired about the administration, inquired about the co-administering medication, and importance of testing after medication. So this baby complaints there was an issue. So mother was reassured, dose was readjusted, and subsequent TSH T4 was normal. So baby was continued for 3 years. And I want to recheck for the permanency of congenital hypothyroidism. As earlier said, need to stop thyroxine supplementation for 4 to 6 weeks and need to reevaluate for nuclear thyroid scintigraphy and USG neck. Then that will give a clue of whether the thyroid is a permanent or a transient variant of congenital hypothyroidism. So in second case, as there is a thyroid dysgenesis, there is no need to check for the permanency. Already it is a case of thyroid dysgenesis. It proves that it is a permanent congenital hypothyroidism, require treatment for the lifelong. So moving to the third case, male baby, 2.9 kg, thyroid profile done on 30, which is of serum units. Free T4 is in the normal range. So what should be the next course of action? Earlier discussed more than 20, but it is not more than 40. It comes in between 20 to 40. No need to do immediate screening. We need to do screening in second week, maybe 1 or 2 weeks of life. If TSH is more than 20 after 2 weeks, less than 2 weeks, or more than 10 after more than 2 weeks of time, so need confirmatory venous sampling. If it is positive, need treatment. So coming to the case, as TSH is 36, in second week of life, we have repeated TSH is 18, free T4 is 1.6. It is a borderline high TSH and normal T4. The possibility it could be transient or permanent congenital hypothyroidism. It could be delayed maturation of HP axis, maybe because of the thyroid hormone resistance, maybe baby having Down syndrome. So Down syndrome baby have a delayed maturation of HP axis, maybe secondary to pseudo hypoparathyroid condition. So in these conditions, there will be borderline high TSH and normal T4. These babies without explaining about the importance of the follow-up and evaluation should not be discharged. So with the intention to follow up, we have to explain the parents and ask for the re-evaluation, recheck for the TSH and T4 after 2 weeks. If it is normal, no treatment. If it is still elevated or TSH more than 10, after 3 weeks of life, even with normal T4, need to start the treatment. And at 3 years of age, we can give a trial of therapy, look for the permanency of the congenital hypothyroidism, and take a decision should we continue for the lifelong or not. So we have repeated this after 2 weeks of life. TSH is 7, normal is T4. As TSH is slightly higher, so also serial values is evident that from 13 to 18, 18 to 7. So even the age of baby is after 2 weeks, TSH is less than 10 only and decreasing trend. So for this baby, treatment is not required, imaging is not required. In these borderline cases may require referral for the expert opinion. So this child is serially monitored. After a few more months of time, TSH became normal. So this baby subsequently not required any medication. Moving to the case 4, T4 is normal. So moving to the case 4, we have a full-term 2.7 kg boy baby with Down syndrome. Cord blood TSH is 15. So less than 17, we consider for the normal baby as a newborn screening. Whereas a Down syndrome baby, we consider as a at-risk baby. Even though newborn screening is a normal, so we have to ask for the recheck. So again, I'm reiterating and re-ensuring that what are the condition, even though newborn screening is normal, when to call the babies for the second screening. In preterm babies, all babies less than 37 weeks of gestational age, baby having low birth weight, sick babies admitted in NICU, multiple births like monozygotic twins, first screen taken after transfusion or exchange transfusion, or baby having underlying Down syndrome. So these are the condition. When the first newborn screening is a normal, still we should call them for the second newborn screening. So as in this case 4, even though newborn screening is a normal, we have advised them to screen at 2 weeks of life. Subsequent TSH suggestive of 36 milli-units per liter. As it is a screening test, so in these times, screening test is venous blood. So rather than doing TSH, it is better to do free T4. So we have done TSH and free T4. That came to be TSH 28.5, free T4 1.54. So even though free T4 is normal, TSH is elevated, and baby having at risk Down syndrome, we have repeated further nuclear scanning suggestive of normal uptake of thyroid gland. So thought of thyroid disharmonogenesis, congenital hypothyroidism. This baby was started on thyroxine supplementation. So earlier I have explained. So these are the conditions for the falsely normal newborn screening. So what are the conditions for the falsely normal newborn screening? Down syndrome, preterm, multiple gestation, sick newborn baby, or baby received any transfusions earlier. So in these babies, there will be falsely normal newborn screening. So these babies need further evaluation. Not only that, there will be methodological errors, failure of sample collection, unsatisfactory samples, misinterpretation of samples, unsatisfactory recalls. They may be reserved for the falsely normal newborn screening. Falsely negative results may be preterm. They may be have a low HPT axis maturation. So they may be low rise of TSH. So TSH rise may be subsequently. So initially they may be reported as a false negative, but subsequently they may become positive. So preterm babies, VLBW babies, critically ill babies, post-transfusion babies, monozygotic twins, they may have a false negative normal newborn screening. So need further evaluation. So coming to the conclusion, every newborn baby must be screened for congenital hypothyroidism. Newborn screening, if early discharge is advisable, can advisable to do the cord blood. If the baby or mother is going to stay for quite some time, it is better to advise postnatal heel prick, preferably after 48 to 72 hours of life, but not beyond 1 week of life. So between 3 to 7 days of life, and if possible, peripheral venous sample after 1 week of life, and it act as a both screening and confirmatory test. So all newborn babies where screen TSH suggests of more than 20, whether it could be cord blood, it could be like heel blood or peripheral venous sample, need for the recall, and we need to reconfirm the baby with confirmatory venous test. Less than 2 weeks, TSH more than 20, more than 2 weeks of chronological age having more than TSH 10, need re-evaluation, reconfirmatory test, and need to confirm hypothyroidism before discharging. And all those babies should be treated. And for the evaluation, when there is a desirable, we need to advise imaging studies like nuclear scanning, technetium 99, and ultrasonography, but we are not supposed to delay the treatment for doing only imaging purpose. Whenever we are going to treat, we have to treat with high dose, whereas acquired hypothyroidism we have to start with low dose, whereas a congenital hypothyroidism we have to start with high dose, 10 to 15 microgram per kg per day. And we have to counsel the parents about the administration of thyroxine and need for the compliance and follow up. And not only we need to do biochemical monitoring during follow-up, we have to do clinical monitoring with growth and developmental assessment during follow-up. So just as a brief, whenever there is a baby, cord blood TSH more than 20, heel blood more than 20, or any venous blood more than 20 need re-evaluation. So whenever at the single point of contact, TSH more than 60 or 80, do immediate confirmatory test, go for imaging, start on immediate treatment with 10 to 15 microgram per kg per day. Any value TSH less than 20, no need of any recall, safely you can discharge the baby. But before discharging, you have to see age reference values. If it is within the reference value, no need to worry. If it is just above the reference value or borderline, refer to pediatric endocrinologist. Or you do confirmatory evaluation after few more weeks. If still they are borderline elevated and child having symptoms, treat the condition rather than just wasting of time. If all TSH between 20 to 80 or 20 to 60 need re-evaluation, maybe 1 or 2 weeks of time. If after 1 to 2 weeks of time, TSH and T4 are away from the reference value, treat the condition. If the borderline, then refer to pediatric endocrinologist. The take-home message is all babies before discharging should be screened for congenital hypothyroidism. In suspected cases, should be confirmed and ruled out congenital hypothyroidism before discharging, or like before stop following the baby. All confirmed congenital hypothyroidism babies should be treated adequately with adequate monitoring. So hypothyroidism is one of the treatable causes of mental retardation. So in developing countries like India, newborn thyroid screening is a birthright for the babies. All babies should be screened for congenital hypothyroidism. With this, I'm closing with my, I came to end of my presentation. Thank you, everybody. If any questions or queries are there, you can ask in the chat box. Yeah, as per the Dr. Vishnu Reddy, what are the guidelines for screening of preterm babies? As earlier said, for all preterm babies, like term babies, we have to do newborn screening. If it is cord blood, immediately after delivery. If it is a heel prick, after 40 to 72 hours of life. And this newborn screening should be done within 5 or 7 days of life. If newborn screening come positive, it could be a false negative screening. That is the reason all preterm newborn babies need second time newborn screening. If still newborn screening second time came negative, safely you can discharge. If comes positive or borderline positive, need early refer to the pediatric endocrinologist. If there are no further questions, I would like to stop my presentation. Thank you once again, everybody. So yeah, before just in preterm, the 27 weeks baby TSH normal, but 27 week baby TSH normal, but 3-4 less than 1. Then do we need to start levothyroxine? So TSH is normal, T4 is less than 1.1. It comes below the reference range. It could be delayed maturation of HPT axis. It could be secondary to maternal hypothyroid antibodies. It could be central hypothyroidism. So we don't know whether it is a evolving normal thyroid or evolving primary hypothyroid, or it could be central hypothyroid. So this baby need further newborn screening. Depending on the screening value, then we have to take a call. Should we treat or not? So thank you so much. With this, I am concluding. I'm stopping my presentation. Thank you.